Thank you very much, and thank you for BMI for asking me to do this presentation on cervical screening. But I did say I want to talk about something new, which is the new surgery we're implementing, which is laparoscopic hysterectomy. So there's a second half of this presentation, and there will be a video at the end for you to watch, so you can see exactly what we're doing. So without further ado, I will start with cervical screening changes and implications for primary care. Sorry, I will bypass that. If you have any complaints, by all means, you can talk to me later. This is what I do nowadays when I'm not at Northwick Park. Right, so going back, cervical cancer is the second most frequent cancer in young women worldwide, and indeed in Europe. It's a big problem. It's not a big problem in the UK because we have cervical screening, but if you go to other countries, particularly developing countries, it's still one of the biggest killers of young women. We mustn't forget that. Again, one of the messages that I always like to get through, which I'm sure you're all familiar with, the biggest risk of getting cervical cancer in the UK is not having your smears. It's nothing to do with sexual activity. It's nothing to do with anything else. It's not having your smears. We audit all the cervical cancers we get very frequently. In excess of 50 to 60% have either never had a smear or have not had a smear for the last 5 to 10 years. So I think there's a strong message there, irrespective of any of the changes on HPV, which I try to focus on. Right, so John Pitkin kindly introduced a couple of scenarios. First one, 26-year-old has a smear showing mild dyskaryosis, is HPV positive. Scenario 2, 26-year-old have a smear showing mild dyskaryosis, HPV negative. One is discharged to normal recall, the other is referred to colposcopy. And clearly that marks a sea change that has happened over the last few years. And for the ones of you who are interested, this is a mildly dyskaryotic cell. It means that the nucleus is enlarged, there's been more chromatin, and most of the cytopathologists would recognize it and agree that this is the case. Again, I'll just put a couple of things that might be interesting to any of you who have an interest in cytopathology. But we now know that HPV causes cervical cancer. Professor Zuhausen from Germany stood up at the British Society meeting a few years ago, quite a few years ago, and stood up and said, what causes cervical cancer is HPV and bad luck. He's right. He got a Nobel Prize. He deserves to. So we know that now. What has changed over the last 10 or 15 years is technology, the ability to identify HPV accurately and knowing what is what. What hasn't changed is the prevalence of HPV in the world. Just because we find HPV, it's a bit like Columbus finding America. America wasn't lost. America was there. HPV has always been there. We are able to identify it now. And it causes concern. It causes concern to us. It causes concern to our patients. So how do we move on? More than 20% of women at any given time may be infected, particularly if they're young and obviously sexually active. But only a very small proportion will develop dysplastic changes. Clinical studies, again, this is the 2000 studies, so that 99.7, I can tell you this is 100% of cases of cervical cancer is caused by HPV. But also, we know that mucosal HPV infections can be caused by other types which are not oncogenic. So, sorry, I know you just had your lunch, but it's only going to get worse. What do you expect? Oncogenic high-risk HPV. For the ones of you who've been to colposcopy, I'm sure Councillor Carey is somewhere over there, and I'm sure he remembers very well that this is high-grade CIN on colposcopy, and this is caused by high-risk oncogenic HPV virus. And we do know that in Europe, 16 and 18 subtypes account for more than 75% of all cervical cancers. But there are non-oncogenic viruses, such as 6 and 11. They cause good old-fashioned, annoying but boring genital warts. And of course, this is a huge area of expansion both for our knowledge, for our treatment, but also for the industry which come up with vaccines, which I will very briefly mention. Okay, this is one of my favorite slides. Went over to San Francisco, nice place to go. Also had a big meeting with the American Society for Cervical Pathology. I like Americans, they just say it as it is. What does this tell us? Well, sensitivity for high-grade CIN. I think the main message is don't have your smear in Germany. Okay? But, well, I'm sorry, I hope I'm not offending any German here, but it's true. In UK, we're doing pretty good. In other parts of the world, comparable when it comes down to a pap test. HPV accuracy doesn't matter. Doesn't matter whether you have it done in Germany, here, or anywhere. So it's quite accurate. Actually, it's more accurate than the pap test. You can see that in sensitivity for CIN2. So, based with all that, the NHS cervical screening program back in 2006 decided how do we incorporate this knowledge in the national screening program. And there were a lot of pilots. Pilots means we choose in a hospital, and we were the only pilot in London in 2008. We were called the Sentinel site for implementation, which means we were given a lot of money, and we were carrying a lot of colposcopies on women with HPV tests, and this was the pilot. Of course, as you know, once the pilot money runs out, it's expected that primary care has to pay for all these things out of your budget. So how can we do it right? Well, initially this is a very busy protocol, and I really, really don't want anybody to try to learn it because I still haven't learned it 6 years later. Effectively what it says is that if you have a low-grade smear, that's a borderline or a mild dyskaryosis, it's HPV negative, you can just reassure the patient that they do not need to worry and they can go back to normal recall. If they're HPV positive and they do have an abnormal smear, they come to colposcopy. I think more or less it sounds fairly simple. And this is the algorithm we try to follow. Of course, the problem is, what happens next? So yes, they come to colposcopy, yes, they do have low-grade CIN, yes, we can see it. What do we do next? It's an infection, it takes its time to resolve. Do we follow them up in colposcopy? Do we discharge them? A lot of debate. We meaning Northwick Park and Hillingdon, which were the central sites for London, decided that we didn't have enough evidence to discharge patients simply on one colposcopic opinion. Therefore, we carry on looking after them for a while, and we just presented to the British Society our outcomes, which obviously showed that perhaps our colposcopic opinion wasn't as good as it should be. So a lot of questions to be answered still. So, liquid-based cytology is something that you're all familiar with, and if it's high-risk HPV, you refer to colposcopy. If not, you return to routine screening. Again, the rationale that the predicted value of an HPV test is over 90%. So it's a pretty good test. Right, okay, well, what about the other side? Well, HPV testing explicitly links sexual transmission to disease. The smear doesn't. Women used to have smears. If they had an abnormal smear, they would come and discuss it. Now, I have to say, I don't know about your surgeries, but half of my colposcopy clinic is a bit like the Jeremy Kyle show. Who did what with whom, and I didn't do this, and he told me he didn't. And do you know what? It's difficult. It's difficult. It is indeed very difficult. And we need to address that. We need to reassure people we're not there to discuss who's done what with whom, but to discuss about cancer and the risk of cancer. And invariably causes concerns about transmission. I think we'll address that. Some women feel stigmatized. And unfortunately, there's some evidence that because they feel stigmatized, they may not come for colposcopy. So that's a concern. That's an ongoing concern which we need to address. So, for the ones of you who work in Hillingdon, you're a pilot again. I made sure that Northwick Park is not a pilot. Hillingdon is the pilot of primary HPV screening with or without pap smear. And it's an interesting one because recently I saw a lady in Bishopswood 2 weeks ago who says, doctor said I went for a smear test and they didn't do it. Oh, okay. I got the result to say they did an HPV test. It's negative. And they say, I'll go back to 3 years. Therefore, they didn't do which is true. Because now there's a new pilot. After we've done 6 years pilots with smear being part of the original screening, now smear is cytology, shall I say, for dyskaryosis, is reflex. Now this is an algorithm. I'm not sure this is the algorithm that applies to Hillingdon, but this is an algorithm that we worked out with the American Society. And effectively what it says, look, the reality is that if you're HPV negative, your risk of cervical cancer is virtually zero. You can go to be recalled every 5 years. If you're positive, then we do the cytology to see exactly what's wrong with you, and you go for colposcopy. The Americans are very sensible, in my opinion. They repeat the HPV test, they repeat the colposcopy, and they literally track the disease till it's resolved or not. Obviously, in the UK, there's no money for that. So, the proposed new screening, which will, I think, become national, will shift to screening for HPV infection, and targeted screening will replace mass screening. Using HPV DNA test, women who test negative will be simply rescreened for HPV in 3 to 5 years. The ones who are positive will have reflex cytology, and if it's positive, they'll go to the colposcopy. If both tests are negative, 6 months later, they should be discharged again. Okay. We have not really addressed the concerns of women with an HPV infection. What we haven't said is that most positive results represent a transient infection that will regress. Primary HPV screening cannot differentiate which CIN is going to progress and which CIN is going to regress. And it says here that it will miss some of the lesions because at the time of inception, the primary HPV screening was only checking for 16 and 18. I understand this has now been corrected, so they will be checking for more oncogenic viruses. Also, the HPV screening is linked to the vaccination, because the idea is we vaccinate young girls now, so in 10 years' time, if you've been vaccinated and you are HPV negative, you will probably not need more than 1 or 2 smears in your life. That sounds brilliant modeling. That means that you've stayed in the same place all your time, you haven't come from another country, and you haven't had a partner that came from another country. That's not real life, is it? Unless we go for a universal HPV vaccination, girls and boys, we're not going to achieve these targets, but that's not going to happen. It happens in Australia, but not in the UK. I do not know the vaccine take-up rate in various parts of the UK, but we do know from the American modeling that the highest socioeconomic classes, which actually at lower risk of cervical cancer, took up the vaccination quite well, whereas the lower socioeconomic states in America didn't. So it's difficult to know what's going to be the effect of vaccination in the future. And let's be honest about it, there's a lot of money with vaccines, and it just happens that the same companies who find and work with HPV in the lab, they also are manufacturing the vaccine. So there's a lot of interest there. So what about the good old pap test? Because what worries me in all this is that the good old pap test is just kind of forgotten. The pap test has been with us for many, many years. And if it's done properly, we do know that it reduces cervical cancer rate between 60 and 90%. Yes, it's not as accurate as HPV test, but we've been for it for many, many years. And it can be even more accurate with liquid-based cytology. I don't think we should be throwing it in the bin yet. Also, we as colposcopists know very well what to do with a mild abnormal smear or a moderate abnormal smear, colposcopy, follow-up, treatment, everything. I'm still quite uncertain what I should be doing with a HPV test that's positive, but the smear may be negative, for example. What is the risk? Again, I have to turn to how women feel about it, our patients. Women have known that pap testing is effective. For many, many years, it's become part of a woman's well-being life. HPV is new, and if it's also accompanied with a reduction in the amount of screening, then there's a good possibility that it may seem as economizing, i.e. we're having less tests. The biggest problem we have in London is non-attendance. When we look at all the graphs from all over the country about coverage, and of course this is something that you're very, very much in the front line, London coverage is very small. It's the lowest in the UK. It touches somewhere between 70 and under 80%. Any screening program under 80% will miss things. We do know there's a big transit population in London. There are also a fair amount of people who don't permanently live in London. They're from other countries. So to have a test which actually does not make it clear to women what it's about, I have a concern that unless we make it very explicit and we get you, the primary care, on board, we may see that the DNA rate for cervical screening may drop. May increase actually, so the actual attendance will drop. And that is, just to go back to the beginning of what I said, the biggest risk of getting cervical cancer. So, this is a graph to show the impact of new referrals from when we, as a pilot at Northwick Park and Hospital in Central Middlesex, where I'm in charge for colposcopy, had on the number of referrals. Now remember, these are now direct referrals, so you don't actually need to refer. They are coming directly to us. And you can see that the amount of work we had at Northwick Park, Central Middlesex, it didn't quite happen, I'm not sure why, was exponential. This is the same findings in other sentinel sites. And as I said, at the time of the pilot, we were paid per case. That is no longer going to be the case. We need to find a modeling by which we are seeing these women as soon as possible, and we're asked to discharge them very, very soon. The problem with discharging them very, very soon is that they still have a low-grade abnormality, they still come back to you, and there's a lot of questions to be asked. And of course, this is why we need you on board. Okay, this was the first part of my presentation, but I said I would really like to be a little bit more upbeat, because I didn't sound very upbeat with the first bit. And I'm going to talk something very close to my heart, something that I introduced in Harrow in 2011, which is total laparoscopic hysterectomy. It may be that some of your patients have already had one, and it may be that you might wish to tell them what we do. It all started with a nice guidance which said that we should be treating most, if not all, endometrial cancers with laparoscopic hysterectomy. And NICE was quite explicit. It compared the outcomes for cancer, the outcomes for morbidity, as far as laparoscopic hysterectomy is concerned. And what they found is quite evident. If you have the technology, and if you be trained properly, the outcomes should be comparable as far as cancer survival is concerned, and there's a lot of advantages for women if they have an operation with a laparoscopic route. Now, all of you are experienced practitioners. You can imagine that the average woman with endometrial cancer is of a good BMI, so we say. She probably has other comorbidities, such as diabetes, heart disease, and the risk of infection, DVT, and everything is quite exponential. Unfortunately, in my older practice, I have cured a lot of endometrial cancers only for the patient to die of a heart attack or a DVT, and that was not quite nice. So laparoscopic hysterectomy is here, and as long as the skills are there, we should be able to do it. So I took myself over to Canada. I spent some time at the McGill, where people do this all the time. And I was pleased to be able to introduce with a team of colleagues at Northwick Park. So these are slides to say that NICE says it's safe, and it also says that the outcomes should be the same. They should have fewer problems. Speaking of fewer problems, what do you expect your patients to gain out of laparoscopic surgery? It doesn't have to be for cancer. It can be for any benign condition that requires surgery. For hysterectomy, that is. Less pain, less wound complications, less hematomas, less hernias, less disruption to bowel and bladder function. Risk of infection with DVTs goes down significantly. Minimal adhesions, cosmetically a much better result. And most important, particularly for the secondary care, significantly reduced length of stay. So this is what we're aspiring to, and obviously we do a continuous audit. I'm pleased to say that the figures I present to you today are combined figures for Norfolk Park and the Clementine, where this procedure has been introduced thanks to John Hale's support. As we speak, we have actually 55, but when the slide was done, it was 54 patients. Cancers and hyperplasia is by far the biggest group, but we've got fibroids, dysplasias. Because we work very closely with St. Mark's Hospital, we have Lynch syndrome as well, which is a genetic condition that affects the bowel and the uterus. Now, length of stay is the obvious thing we looked at. And yes, we did have a blip. We did have one bowel injury. The lady stayed for a very long time. She's very well, I'm pleased to say. But you need to see this from the bottom up. Initially, it took us 4 or 5 days to discharge the patient. That's because of the mindset of SHOs on the ward. Oh, you can't go home till you have bowel sounds. Well, you know, when I'm hungry in the morning, I don't listen to my bowel sounds, I go have breakfast. So that's what we did. So first thing in the morning, if the woman is hungry, we just feed them. And take the catheter out. Yeah, of course, if the only reason to have a catheter in is because people can't walk, but if they can walk. So nowadays, it's becoming standard to say, first thing in the morning, catheter out, food in, go home. So at the moment, we're working on 2-day stay. Thank you very much. Sorry about that.
Well, you know, this is very good. Can we have some questions? Mrs. Sarhanis, yeah, one at the back over there, please, find the door.
Hi there, thank you. 2 questions. Is the HPV test, is that a self-swab? That's the first question. Secondly, who doesn't qualify for a total laparoscopic hysterectomy? Is there anybody that you wouldn't do that with?
I'll take the first question first. The HPV test is done as part of the smear. Sorry, I can't see you because it's quite dark. Sorry, apologies. It's part of the HPV, it's a part of the smear test, so it's done with the same brush that is we do for the smear test. So it actually goes in the same vial, and then they separate it in the laboratory, so you don't need to take a separate test. It's done on the same. Who qualifies for laparoscopic hysterectomy? Well, we do choose our patients carefully. Having said that, we don't, I'm lying, because anybody who comes with endometrial cancer now is expected to have this one. As long as the uterus is deliverable vaginally, I don't have a problem. And as long as there has been extensive surgery. So I would say anyone who requires a laparoscopic hysterectomy is a good candidate for laparoscopic hysterectomy unless there's any specific reason, which also would be a problem for an open hysterectomy.
Right. Are there any tests for HPV type 33 and 44 that are oncogenic for squamous cell cervical cancer?
Yeah,
this is my first question. The second one is why did you close the vaginal vault? Why did you not leave it open for drainage?
Okay, they're both very good questions. I did say Europe. Now, for some unbeknown reason to me, 16 and 18, the masters here thought that people are only from Europe. If you go to Trinidad, where I went, 45, which you mentioned, is one of the main oncogenic viruses. But somehow, I'm not sure there's a vaccine for 45. We do check for it. So 33 and 45 are in the basket of HPV testing. The problem, of course, you can see the discrepancy with the vaccine. Okay, you can test for this thing, but there's no vaccine for it. So it can, and that opens a can of worms. You're absolutely right. According to the American statistics, you're absolutely right. Why do we close the vagina? We don't have to. One of the problems of any hysterectomy, and it has been reported with laparoscopic, is evisceration, unfortunately. And there have been cases, and Joan and I have been in this business long enough to know that occasionally, after any hysterectomy, a woman may come with the bowel in the vagina, and that is an absolute nightmare.
I have also noticed that you did not ligate the uterine artery.
We did.
Did you have, it was just coagulation, isn't it?
Yes, that is.
No stitches?
Nope.
Do they not really, is there no risk that they could really open up afterwards
Nope.
and cause bleeding?
Nope.
Right, that's good.
Simple as that. Sorry.
Straight on. Straight on. Over here again. And then next one is there.
My question's about HPV and a normal smear. So I had a patient who privately had a smear test which was normal, but HPV, a high-risk HPV was positive. I don't know which one it wasn't 16 or 18. And then a year later she had a NHS smear test which was normal, and they didn't test for HPV.
That's right.
And I wasn't sure what would you do with a normal smear and this potential high-risk HPV?
Well, this is part of the dilemmas that we were discussing earlier on. What I tend to do in this case is follow the American protocol. The American protocol is pretty clear. If you're HPV positive, you need a colposcopy. That does not apply in the United Kingdom, because if you have a negative smear test, you should not have been checked for HPV. Therefore, I have been known, of course, even on the NHS, to do the colposcopy. My cytopathology colleagues don't like it, and of course the smear that comes with it has a completely different recommendation versus the British recommendations. The very good point you're asking here is what's going to do with primary HPV screening. Is primary HPV screening going to look at negative smears or not? So if someone has a primary HPV test which is abnormal and they have a normal smear, are they going to be sent for colposcopy or not? I do not know the answer to that. I personally think they should, because the role of colposcopy in that scenario is pretty simple. Exclude high-grade lesion, nothing else. If it's transient infection, it will just go away. Sorry, was there a second question? I can't remember. No, sorry.
I've got several patients who decline to have any smear tests because they say they've never been sexually active. Is it okay to just reassure them that as they have never been sexually active, they shouldn't really be worrying about cervical cancer, or should I be trying my best to convince them? And if they won't accept a speculum examination, is there any way of testing them for HPV sort of non-invasively?
Yes, there is. There are kits available where you can do a swab. I think one of the ladies suggested it for HPV. Kind of difficult one. If you're not sexually active, how do you get HPV? Let's be serious about it. The second part of your question is a good one. About women who've never been sexually active, then they can be excluded from smears. My problem with that is the understanding. I've had at least one patient with cervical cancer whose understanding is that she has been sexually active for a long time. So the never and a very long time may be confusing. When we went back and said, well, actually she was married and then divorced for many years, so it's a difficult one. We do encourage people to come for the smear test, but you're absolutely right. That particular group of people is really at a minimum risk.
There are two final ones over in the corner there.
I guess just following on from that, the take-up of smear tests and HPV testing in those women who are in same-sex relationships can be low, and do we find that, what would your recommendations be on that?
The same-sex relationships are under exactly the same rules as opposite-sex relationships. They're exactly the same risks. There's HPV that's been identified on sexual aids and stuff like that. So the rules are that it doesn't matter, as long as you're sexually active, you should be having smears, and same-sex relationships are not excluded.
Hi. Just to clarify this further, now you mentioned that if it's CIN1 and HPV positive, they go for colposcopy. And in the colposcopy, obviously they do biopsies and all that, and they may they do a LET or something like that. But is there a test for cure after that? Or how does that work?
A test of cure I did not mention, you're absolutely right, because test of cure is something we do after treatment. Test of cure is probably the most successful part of cervical screening. Test of cure means that if you have had treatment, i.e. conization of the cervix or a lip or a loop, whatever you want to call it, 6 months later, by doing a smear test, if you're HPV negative, you can be safely discharged to the cervical screening program. So you're absolutely right. Test of cure applies to treatments, not to diagnostic